Hello guys, um, this is Dr. T and welcome to Clinical Medicine with Dr. T. So guys, what I want us to talk about, I hope you guys are good. I hope you guys are doing great. I hope you guys still enjoying the channel, and I hope that you're still gonna comment, like, and share, and also spread the word for me so that we can grow as much as we can. The plan is for us to be known in all varsities in South Africa that are doing medicine, that have medicine in their programs, before we can go international. I believe we can go international, but let's see. So guys, what I want us to talk about in this episode is diabetes. And what we're going to talk about is not how to diagnose diabetes, the pathophysiology, not even the management, but what I want us to talk about here, actually it is part of managing diabetes, but what we're going to talk about, it is part of managing diabetes, but we're not going to talk about the drugs and all of that. What I want us to talk about is the screening for the microvascular and the macrovascular complications of diabetes. When should it be done? So basically, this tutorial is going to help us to know when we get a diabetic patient at the clinic, what do we need to do? What do we need to do? And we all know that you can't even go a day without seeing a diabetic patient if you are in internal medicine or in female medicine. So how should I title this? Okay. What to do with a diabetic patient at the clinic. Why am I saying at the clinic? Remember, when it comes to diabetes, diabetes kills in roughly 2 ways. So you've got the diabetes. Diabetes can kill someone in the form of diabetic emergency. And when you talk about diabetic emergency or emergencies, we're talking about you've got your hyperglycemic state or conditions. DKA is under this one, and also hyperglycemic hyperosmolar state is here. Those are your hyperglycemic states under diabetes emergencies. Then we've got your hypoglycemic. Then we've got hypoglycemia, basically. Yes, hyperglycemia can kill you, but yes, you'll have seizures and before you can die and other things. But yeah, it can kill. Actually, yeah, it can kill. So, because remember, your brain can only use the glucose that is available in the blood. It does not store glucose and doesn't have the ability to convert non-carbohydrate substrates into energy. Okay, so it can also kill in the form of complications. Many people, they don't die from hyperglycemic states, like here. Many they die because of complications, and we know that the complications can come in the form of microvascular or macrovascular. So when you talk about microvascular, we're talking about things like retinopathy. We're talking about things like nephropathy and neuropathy. How can someone die from a neuropathy? Because when you talk about the neuropathy, most of the times we are talking about when we talk about neuropathy, most of the times we are talking about the foot, but people tend to forget that diabetes is not selective in terms of which nerves it's going to damage, but it's well known that it damages the nerves of the legs or the foot. But there's something called autonomic neuropathy. So diabetic patients, they don't get a typical chest pain. Like they don't get a rotational chest pain when they are experiencing an MI. So they get a silent MI. The reason why they don't get a chest pain or a typical chest pain is because they have autonomic neuropathy. So the sensation from the heart is impaired because of that autonomic neuropathy. And those things, and autonomic neuropathy is not only seen on that, even hypostatic hypertension. So you also get those. So it's someone basically who, when you're diabetic, when you are lying flat, you shouldn't just wake up, stand up very suddenly, or all of a sudden. You should first sit on the bed so that your blood pressure can start to normalize, so it can start to adjust, because you were in a recumbent position before, or a supine position. So once you sit, you are giving your blood pressure or your baroreceptors some time to adjust and see that, okay, now you are no longer lying flat, you are now sitting on the bed. Then now you start walking, but you cannot just jump from being recumbent straight and start moving around, because you are going to have that hypotension that I was talking about. So now so those things can give you problems. You can faint, you can hit your head and get a bleed. You can, if you experience hypotension, and that's all because of that's all because of autonomic nervous system damage from the diabetes, the autonomic neuropathy. And also, how will someone who's got a neuropathy of the foot die from diabetes? Once you get a neuropathy of the foot, they tend to develop diabetic foot ulcers, and they die from sepsis because of that. Especially if they're not amputated or they consult late, so things like that. People have died. Some will go to for operation and not make it out. So it's very, very important. So never take neuropathy lightly. Obviously, nephropathy will kill you. You're gonna get kidney disease and all of that and all of that. With retinopathy, if you can't see, you'll start. Not being able to see is depressing. Some people get into depression because of that. Some people, they start to touch fire. They started to. It's just dangerous not to have your eyesight. It's not a nice thing. You injure yourself, you fall, you do all sorts of things. So now let's talk about yes, I'm not being detailed about any of these things here. So your macrovascular, your CVA, your stroke, your ischemic heart disease, MI specifically, and your peripheral vascular disease. Those are your macrovascular complications of diabetes. So the talk today is going to be centered around this. Today's talk, we are going to talk about emergencies. We are going to talk about diabetes, but I want us to do it in portions. And in clinical medicine, this becomes very, very important. Yes, this is also important, very, very important, but we need to make sure that we know what to do with diabetic patients when they come to us. Okay, now that we have got that background, let's okay, so basically the talk today is about trying to screen patients for these, and based on our results, then we can start managing them. Based on what we see, we can start managing them. So we all know diabetes is a chronic hyperglycemic state because of different problems. So, but basically it's a chronic. Why am I saying chronic? I mean, we all experience hyperglycemia. Everyone experiences hyperglycemia, especially after we've eaten. So we all experience hyperglycemia, but our hyperglycemia of someone who's not diabetic is not chronic. The insulin kicks in and drops the blood sugar again. But diabetes, they have a chronic hyperglycemic, chronic hyperglycemia, right? So now we know that we've got type 1 diabetes and we've got type 2 diabetes. So type 2 diabetes is a slow progressive disease, and most of the times when it's diagnosed, first of all, the diagnosis is usually delayed, and by the time a patient is diagnosed, they normally already, some of them have complications. So which means that when a patient who's diabetic is diagnosed today, it means we have to look for complications immediately. But with type 1 diabetes, it doesn't have a delay in presentation. When someone has got type 1 diabetes, they become symptomatic very fast. I can't give you a time frame, but it's very fast, such that the presentation is so fast that by the time they are diagnosed, they have not progressed, they have not gotten any kind of complications. So most of the times, these ones you start screening them after 5 years, but these ones you start screening them at the time of diagnosis. And we screen for these. So when you have a diabetic patient, there are things that need to be done at every visit. Every time you see the patient, there are things that needs to be done at every visit. There are things that needs to be done every 3 months or sometimes every 6 months. And then there are things that needs to be done annually. Remember, diabetes, when you have diabetes, you have to actively look out for hypertension, because diabetes does cause hypertension. And many people who are diabetic, they are also hypertensive. So there are 3 things. I don't know what triad we should be calling it, but it's just a triad that It's things that you need to always look for. Let me just put it here. So diabetes, most of the times it goes with hypertension, it goes with obesity, and dyslipidemia, dyslipidemia. So when you've got diabetes, actively look out for. That's why at every visit a patient must have a BP check. They must have a weight. They must have a BMI, because we know that diabetes goes with hypertension. It goes with obesity. So we need to check those. So at every visit, a foot inspection must be done. A foot inspection must be done. A foot inspection, I'm going to tell you the difference now. So annually, the things that must be done annually, one of those things is foot examination, a complete or a comprehensive foot examination. We are going to talk about, on this diabetes series, we are going to talk about a diabetic foot, how to examine it, and the pathophysiology of diabetic foot ulcers, all that. A foot inspection, you basically inspect the foot just to see if they've got ulcers, just to see if they've got some like nail hygiene, just to see if they've got callus formation, just to see if they've got anything that is abnormal on the foot. But a complete or a comprehensive foot exam is done annually. That's when now you do your monofilament test, you examine for pulses, all those things we are going to talk about. So checking for pulses, sensation, all those, that's a comprehensive. It has to be done every year for a diabetic patient. That's why it's said that in our setting we don't have a podiatrist, because those people are very good with diabetic patients and their feet. Anyway, so we need a foot inspection at every visit. And also foot inspection, you also inspect for deformities, and also you also counsel them about wearing comfortable shoes that are not tight fitting, because remember, when you've got a tight shoe, the patient when a patient wears a tight fitting shoe, they are at risk of developing barotrauma, and when you get barotrauma, you progress to ulcers. They end up getting foot ulcers. So these are things that needs to be done at every visit. And also they need to be counseled about smoking cessation, stopping smoking. That's a diabetic patient. And every 3 months, when a patient doesn't have, every 3 months, a diabetic patient who's not controlled on their medication, or their medication has just recently been changed, or they've had problems with medication, they need to be done in HbA1c every 3 months. But if the target of their HbA1c has been achieved, and they are compliant, everything is going well, they can do the HbA1c every 6 months, which means there's no diabetic patient who shouldn't have their HbA1c being done twice a year, basically. But if you've got experiencing problems, it should be done every 3 months. Remember, there's no benefit doing a HbA1c in less than 3 months because the span of red cells is 120 days. So doing it this week and doing it 3 weeks later, you're still going to get the same reading because the same red cells that we are testing today, that we are checking, are the same that will still be in the system in the next 3 weeks. So that's the A1C. So I said that you do it every 3 months if someone has just been changed, or they've just been introduced on medication, or if they've been experiencing complications, or if the targets of the HbA1c has not been achieved. Okay, so guys, we're gonna continue on part 2 of this. I don't want us to have long videos. Thank you for watching. We are gonna continue part 2. Thanks.